Hello and welcome to Inpatient Update. I'm your host, Mason Turner, and this is your podcast for practice changing evidence for the working hospitalist. Today on our show, we're doing something different. I'm joined by Dr. Emily Reams as we discuss what actually matters from SHM Converge. Thank you so much for being here, Emily.
Thanks for having me, Mason.
It's a pleasure to have you, Dr. Reams. Dr. Reams is one of my fellow hospitalists. She's an excellent clinician um, and also an excellent travel buddy, as it
Yeah,
turns out.
it was pretty fun.
Yeah. Um, So we both just got back from SHM Converge. That's the Society of Hospital Medicine Converge conference, which it's probably too much to call it the Super Bowl of being a hospitalist, but
Something has to be the Super Bowl.
I don't know. Maybe it's March Madness.
Oh, it was the right time.
What's the right time? But lots of speakers, lots of clinical updates, lots of other stuff, lots of hospitalists. They are all getting together and lots that was very much in the inpatient update ethos of practice changing evidence for the working hospitalist because there was a lot of evidence that we are working hospitalists.
Yes.
So, in this episode, we'll bring what we can from that session to all of y'all at home who didn't get to go, or if you were there and want to recap. Um, Start off, what was your impression of SHM? What was sort of your impression of the overall event, or like what's your biggest surprise? For me, it was probably just how we talked a little bit on the way to the airport, but like how big and how diverse it was. There were so many people there
Yep.
and like old hospitalists, which there are only so many old
Yeah.
hospitalists being like kind of a new profession and all.
Down to residents, med
Yeah, yeah,
students.
yeah. And a lot of young people
Yeah.
and like almost not everything, especially like on the last days, but like almost everything was packed.
Standing room only.
Yeah.
It
A lot of
was
the time
wild. Yeah.
with very hardworking ushers.
Yeah. Aggressive ushers trying to find you a seat. Yeah, I have been doing SHM before. I went in, I want to say 2018. So things were very different then. It was a
Mm,
very pre-COVID world, and there were a lot of younger hospitalists were making up the vast majority of who were at those meetings. I want to say the diversity in this group was much greater, and I
mm,
think this conference was a good bit bigger. Um, it was huge, and the conference center was big, but also like I honestly didn't know there were 60,000 hospitalists out here. So
yeah.
I'm glad our field has grown so much, and even just in those 8 years, it feels like it's much, much, much larger, which is great to see, and the enthusiasm was there.
Yeah. Super
So,
Bowl.
yeah, indeed.
Yeah, it was big. And also I was like, I felt a little bit like I should be going to this all the time because it felt like there was, and I don't know if this is just like because I was aware of it, but it felt like there was a ton of clinical stuff that I learned and that was new. And I'm like, is there always this much new stuff, or is it just that I went so I know it?
Well, I mean, the concern is that they said something in one of the sessions that there were 5 million
Or
papers a year.
the graph.
Five 5 million papers published a year, and I mean, I'm reading what, 10?
Yeah, yeah, yeah.
So maybe 20. So it's nice to have somebody cherry pick what I'm supposed to be gleaming out of this, especially when it's guideline changing. A lot of this stuff was probably up and coming and is not totally relevant for us yet, but there was a lot of stuff that is going to change what we do, and we're going to
Oh,
talk about
totally.
it.
Yep, 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 yep. So let's get into it. I will get into our big takeaways of what's going to actually influence our practice going forward. Um, so Dr. Reams, how often do you have someone on your service who has congestive heart failure
Every day.
every day? What if I told you, at least in folks with moderate to severe, that there was one single medicine you could give people that would reduce both their mortality and their readmission over the year with a number needed to treat of 17? What would you think that medicine was?
I would
I
think
mean,
that
if you've
that
read the
was
show notes, you know what the medicine.
I would think that might be a beta blocker.
Yeah, right?
Entresto.
Ooh, Entresto. The cardiologists love Entresto.
Yeah.
Um, so actually, it's a one-time medicine. You've taken it this year. I've taken it this
Or
year.
else I can't go to work, yes.
Exactly. So the flu shot,
Shocking.
so this is one that I didn't go to the heart failure session, but I was talking to a colleague in the hall who did Rahula Huja, and he mentioned a few of the stuff, and I was like, "Oh, that sounded like that was a better session than I thought," or it wasn't the one I picked. So I looked back at the slides, and I was like, I just saw the slide. If you remember one thing, give your flu shot to everyone you admit with heart failure. And I looked into it a little more and looked at the slides some more. I was like, "Whoa, this
Shocking.
is super cool."
Yeah.
Just a flu shot and 17 patients, which takes like what, like
2 weeks on service?
2 weeks on service,
Maybe?
and you've saved a life and or a readmission within the next year. And for adverse events, they looked at it was a number needed to treat of 15. I love a number needed to
I
treat.
know, I do too, and there's something really nice about a one and done flu shot, and you really are gonna deal with CHF every single day, and you may not convince everybody. Our hospital's really gotten away from being aggressive with the flu shot. It made me kind of think,
Mhm.
"Oh, we do need to get back on that."
I don't think about it. I rarely I don't I don't know when I've given someone a flu shot who was admitted. I was
We
when we
used
were doing
to.
COVID,
Yeah.
I was thinking, "All right, are you vaccinated for COVID? Let's get you vaccinated if you're not." But I honestly don't think about it very much.
And it used to be a lot more aggressive before COVID, which you weren't a hospitalist then, but we used to be very aggressive then about the flu shot. But honestly, we haven't been getting enough in the hospital. And it used to be like a hard stop on the EMR when you were in a chart. If the patient hadn't had a flu shot, it was something that we needed to look at. So, I mean, that's something that we probably should get back into the chart, especially in the
Oh,
fall.
100%. Yeah, we should be triggering this because the patient population they looked at was obviously heart failure. We got impressive numbers in heart failures, but kind of like my takeaway from this is like
It's everybody who's
sick
sick.
people when they get the flu, they get admitted to the hospital and they die.
Yeah.
So most of our population is like high risk for issues from the flu,
Yeah.
and we should be using that hospitalization as an opportunity to protect them from that.
Yeah,
And the
I'd
data backs that up.
I'd be interested to see that in a COPD population
Oh yeah.
or
And
any other.
I'm
Yeah,
sure they've done studies on
but
that, but
I mean, sure. In 5,000,000, maybe I could find one. But yeah,
right.
I think that's a huge takeaway and something that we all should be much more aware of that has kind of fallen out of favor, especially in our facility. But I think in a lot of facilities, no one's triggering the flu shot because the bigger, badder COVID came along and,
Mhm.
it flu kind of is the ugly stepchild now.
Yeah.
And flu was bad this year. So I think it's absolutely something that we should think about.
I don't know remember offhand exactly the time frame of this study, but it overlapped with COVID times.
Yeah.
In fact, I think maybe it was all after COVID times. The 2021's popping into my head. I looked at it briefly when I looked back at the slides. But, like, there was other stuff from the heart failure session, like giving hypertonic saline to help diurese and stuff that, like, you walking away, like, Dr. Huja was like, "What? This was crazy." I'm like, "Yeah, there's that kind of stuff that's underbaked." But then you get to something like this, like 100% I'll be doing this.
Yeah. And I went to a different heart failure session that we didn't talk about the flu shot, but I see a lot of heart failure out in the community and I work in rural hospitals and we're treating some really, really sick people. And, it's always good to have a little refresher. Like
Oh, yeah.
I think I know how to treat heart failure, but like low output heart failure is something that I really need to like keep in my mind. And I think also in the community, I need to be given more flu shots
Yeah.
too. So
Yeah, it's like I think of treating heart failure in the hospital as, like, relatively straightforward, but if you when you don't have the safety net of a cardiology service,
yeah,
it's a lot scarier.
yeah. When you don't have we don't have a unit so you can put somebody on dopamine or
Yep,
dopamine. So
yep.
but it's good that actually that session, we haven't really talked about this, but that session was helpful for me because it helped me identify some early markers that I needed to look for, like a lactate or if the creatinine's going up, and reminded me to do silly things like touch somebody's feet to
Mm,
see if we were actually in low output instead of we're over diuresed when our creatinine starts bumping. And it's helpful then because I can get that patient to a place that's got a cardiologist, whereas they're sitting on the floor in these tiny hospitals and things can go south kind of fast. So
Yeah.
Heart failure session was, kind of a banger.
Really?
Yeah.
Ooh. See, I'm sad I missed it.
Yeah.
Everything I hear about the heart failure stuff is like, "Oh, this was good." Yeah, touching patients doing the physical exam. I feel like that's one thing like if I'm talking to learners, I say one thing that's kind of more than what I do in practice in my physical exam is
Yeah.
like, how often do I actually touch legs? How often do I give my shock talk and be like, warm versus cold and all of that stuff? And those things don't really correlate, but they should.
They
And so
should.
that's
Yeah.
part of what was great about the conference is it was just a reminder of stuff like to give a flu shot. Like, duh. Of
Yeah.
course, I should be giving everyone a flu shot in flu season. But the fact that I have this 100% is going to be on my radar going forward. I met someone with heart failure. It's the season when we have a flu shot. I will be giving them a flu shot. I will be giving anyone who will let me a flu shot who gets admitted to the hospital during the time that there's flu
You're gonna
shots.
become a menace
I
just
am,
walking around with a
and
flu
I'm
shot.
gonna save lives.
You are gonna save lives. And I think you should quote this study to all of your patients who refuse flu shots.
Yeah,
I'm
no, no,
just
no.
trying to save your life.
I'm gonna yell it at whoever tells me we're out of the flu shot.
Oh, well, that's actually more likely. We do tend to run out. There's always a shortage.
All right. Moving on. You want to
Yeah,
talk to us
I'll hit the
about
next
a
one.
take? Give us a takeaway.
Mine is also something that has been studied a lot recently, and your patients who are on aspirin for CAD, but also on a DOAC for anticoagulation, generally for AFib, you need to stop the aspirin. And I thought about it, and we do this some, but there are patients that are on aspirin for CAD from a MI that they had in 1982
Mhm.
and have been put on a DOAC in the last 10 years for AFib, and nobody ever took them off the aspirin. And honestly, I've the double anticoagulation, the platelet of it all, the coagulation cascade, it looks like these things are a little more interspersed than we thought they were, and that's great. But multiple trials have shown that stopping the aspirin, you've decreased death from 13% to 8%. So you're more likely to survive. You're less likely to have a major bleed, obviously, and you're less likely to have a hemorrhagic stroke. So the studies
Yeah.
conservatively are saying stop the aspirin a year after a stent, but it looks like you could really do it at 6 months out. Um, and obviously things are different if you're on a Plavix and things like that, but, a year out, it looks like you don't really need to be on an antiplatelet. So, I think that that's something that we can probably change once a week also.
Oh, yeah. I'm totally with you. Um, this was huge. You're right. Like, anything where it's, like, a significant mortality benefit, and if I recall, they, like, stopped the trial early because there was such a
Yes. Yep.
mortality benefit. It's
I
like,
think
"Alright, we're this is doing something."
if you're stopping a trial early, I'm gonna listen.
Yeah.
So I think that was in the things we do for no reason section, which we may get into it, but that's always a great session for the hospitalist to go through
Mhm.
things and cut the fat. But this is something that again saves lives. And I think the biggest thing is major bleeding, hemorrhagic stroke, awful, awful. But like even just the oozy GI bleeds that you're just admitting again and again and again. A lot of those we have already taken off the aspirin, but some of them haven't. And a lot of the cardiologists aren't on this yet. And
No,
so,
yeah. And I wasn't on this until, 2026 at all. Like,
yeah,
I was not. And we actually, I think episode 3 with Dr. Espino, we actually talked about, I think it's Aquatic was the name of the trial.
yeah,
And I hadn't known about it before then, and literally, like, that week, it was changing my practice, and also that week, I wasn't seeing it consistently applied by other services, even like cardiology.
agreed, agreed.
Um, but
It's a way for us to make a difference, though, just by doing a med rec.
yeah, and I'm with you. And I think I said this in the episode, I would always have the conversation because patients even will like kind of intuitively be like, wait, I'm on aspirin and I'm on Eliquis. Why am I on two things to thin my blood? And I'm like telling them, platelets versus coagulation cascade, and it's
Yeah.
different. it's different mechanisms that are causing the clot in different areas, and so it's different. And turns out,
Maybe
like now, yep,
maybe the studies are not so
no,
true. Yeah, maybe
like
not
the
so
obvious
much.
thing that was obvious to those human beings actually is obviously
Yeah,
true. And if we're throwing too much anticoagulation, people were
yeah.
causing more harm than good.
Yeah, I will say 70-year-old men are pretty in love with their aspirin though. So
Oh my gosh.
we are going to have to do a little education, but it will be worth it, I think, in the long run if you can avoid any sort of major bleeding and decrease mortality. Again, something else we can do to save lives.
Um, yeah. On the other end of the spectrum, my 70-something-year-old father who's like, I bleed really easily. So why am I on the aspirin? I need to not be on
Good
the
for
aspirin. I'm
him.
like,
Good for
let's
him.
get you off it.
Advocate for yourself, sir.
Yeah. um, I think it's super cool that we've hit this. We've talked about, all right, we're saving lives. And so far, all we've suggested that we do is stop a medicine
Yep.
and do a flu shot.
Yep.
And this is what I really like about evidence for a hospitalist is like our reps are so high. We see so many of these people who have coronary artery disease and a reason for anticoagulation, or we see so many of these people who have heart failure and are admitted to the hospital
Yeah.
that like we don't need a fantastic number needed of treat to the teens to make an impact. But like when you can do that, not by doing some new fancy medicine, not by doing something that sounds wild like giving someone hypertonic
Like
saline,
saline. Yeah, I'm
but you
not sure on
can
that
who's
one.
in a heart failure exacerbation. But the fact that you can just take these patients and do really simple things that make an impact
Yeah.
is like super cool. And the fact that we're learning these things in 2026 about aspirin and a flu shot,
Yeah.
it's like, wow, like how did we already know this? And why were
There's
we doing it different?
so much out there.
And I am like, how did these studies get funded? Because no one's making money off of stopping your aspirin or doing flu shots.
Nope. I mean, I guess the big head bleed is is really glad that we're doing that. But I think overall, yeah, so far for hospitalists, these two have been easy to implement. And I think there'll be a lot of patient buy-in with both of these. I don't think that there's gonna be huge scary changes to be made.
Yeah, she says, you've already alluded to how, yes, there will be good patient buy-in, but telling people to take vaccines and taking away a medicine from someone that someone told them at some point in their history they really needed because it was gonna keep them have a heart attack and a stroke is
All right, you're right.
doable, but easier said than done.
Yeah, you're right. But easy to teach a learner.
Yeah, definitely. Yeah, we'll culture change
Yeah,
over,
yeah. We
our
can
time.
culture change on that.
All right, so let's talk a little bit about sort of the conference in general more, and we're like, travel. Nashville was fun.
Nashville's great, and the conference center in Nashville is amazing. It's huge. It's maybe too big.
It's maybe too big. Yeah,
I
lots of
walked
people.
several miles, getting from room to room. The 10 minutes between sessions might not have been enough.
Yeah.
But yeah, it's a beautiful new conference center, downtown Nashville.
Oh, is it new?
Yeah, a newish.
You know Nashville better than I
I
do.
mean, lots of hotels around. The hotels are all kind of new, fancy.
Do you have
Hotel bars on the top floor, very fancy.
do you have a high low of the trip? A high or a low or both?
I mean, the high of the trip was, you know, getting time away and hanging out with my colleagues that I don't always necessarily get to spend time with, and especially outside of work in a fun setting. That's
Yeah.
nice. The high is getting away from my children. The low is also getting away from my
Oh
children.
my
So
gosh.
it's always a catch-22, but it was nice to sleep
Oh my
through the
gosh.
night. I bet
Yeah.
you know.
Having a hotel room, sleeping through the night, and I agree. Just like the social aspect was really fun. I hadn't been to SHM before, and the fact that like we,
Yeah,
our buddies, and we ended up that we randomly are on the same flight there and back, and
I was
so we got to
lucky.
like hang out. That was fantastic.
Yeah, though on the flight back, the low might be the flight back. I was pretty sure that every child that was going to Charleston was crying.
Noise canceling headphones.
Oh, not enough. And I was also late and like everybody was getting a little anxious. I was real worried we weren't going to get home and I was going to live on that
Oh yeah,
plane
we were on
forever.
there forever. I was asleep for part of it. I had downloaded one podcast to listen to.
Good for you.
I killed it before we took off the tarmac while we still had data and
Yeah.
I didn't have to put my phone in airplane mode.
Yeah, but no, it was great. Getting to Nashville for us is easy and it's a good conference. It's a big conference and so there's a lot going on and there was something for everybody, which I liked. Like, our program director had meetings with,
Mhm.
about leadership. There are meetings for young hospitalists. There are sessions that are specifically for nocturnists. Like, it was there are sessions for teaching pearls on rounds and how to, like, optimize that. Like, there's literally something for everyone, and I think that that's the nice thing about these meetings is it's kinda gonna hit something for you. The worst thing is that you may have 2 sessions you wanna go to at the
Oh,
same
yeah,
time.
what was it, like 7, 8 sessions at a time for the
Yeah.
breakout sessions? And
Yep,
yeah.
there's a lot of stuff that I missed, but again, they publish all the PowerPoints. You can do the digital downloads. They give you options. It's just, obviously sitting in there and listening is a lot easier than reading the PowerPoint later, though your flu shot hits you either way. So,
Yeah.
but yeah, I think overall it's a good conference.
Yeah,
We
super
had
cool.
yeah, we had a really nice experience. You know, I think next year in Vegas
Next year in Vegas.
sounds like a whole different experience.
Yeah, it's been a
But
long time since I've been to Vegas.
yeah, same. But it that could be great too. I think, I won't get as much sleep there. But yeah, I think it's a great conference. What were your highs and lows?
Oh, the same thing. I liked the social aspect. I'm glad we went to that honky tonk. We went to
Oh,
the what was it called? Was it Westworld?
Western World or
Western World.
something.
Yeah, I
Yeah.
should be able to shout them out directly. But like in retrospect, I'm like, oh, Emerson, good idea.
Yeah, one of our
We did
residents talked us into a honky
and
tonk.
we did something very Nashville,
Yeah.
and I was, like, so, like, tuned into the conference and not tuned into, like, "Let's do some Nashville stuff," so I'm glad we did
Yeah,
that.
I'm glad we did that too.
Thank you.
You're
I'm
welcome.
glad we, slept, and in that vein, I don't usually dedicate episodes, but I'm gonna dedicate this episode to and you'll probably
Yeah.
have this exact same thing on your side, I
Yep.
believe, my wife,
Mhm.
my in-laws who
Yes.
helped with, arranging overnight childcare while I was gone, and my parents who were here in person taking care of my children while I was gone. We both have 2 young children, mine younger than yours,
Yours much younger
mine
in
very
a
young.
very scary young age.
So I was, having a, 5-week-old. I was very happy to get the sleep in a hotel and also very grateful to everyone who supported that happening.
I agree. My husband was the rock star of all of it, but along with my parents who the kids slept at their house one of the nights,
There you
and then
go.
also my in-laws who got up at 6 a.m. to come take the kids to school because my husband has to be at work at 6:30. So,
You know how they say it takes a village?
I'm just really thankful for my village.
Yeah, dedicating it to the village.
Yeah, cheers to that. Cheers to
Cheers
the
to that.
village.
Oh, this is also our first, wine podcast for Inpatient Update.
Sorry, I'm not a
Doctor
whiskey
Reams
girl.
said, "I'll come on, but only if there's wine."
Yeah, sorry. Um, it's very specific.
The problem is I didn't get, wine glasses made up, so now I will have to special order some wine glasses that have Inpatient Update,
For
logo on it
for
just for
my
you.
next session,
Yeah,
that'd
yeah,
be
for your
great.
next
Yes,
session,
thank you.
certainly.
Thank you so much. Yeah.
Alright, onwards and upwards.
Are we going to alcohol now? Now that we just talked about
Oh,
wine?
let's talk first, I've got another takeaway. In our vein of anticoagulating patients, this was something from the Things We Do for No Reason session that really struck me. And that was in your patient that has AFib, who's on anticoagulation or you're starting on anticoagulation for stroke risk reduction. The sticky wicket of deciding should you be holding it because you're worried they're gonna fall and get a brain bleed. And
We've all met old people.
yeah, right? Yeah, yeah, yeah.
Yeah.
And so the guideline is generally risk greater than or equal to 2%, which is a JADS VASC of 2 in men and 3 in women. They recommend being on anticoagulation. And I always recommend that to my patients. But I do a lot of this is my opportunity for what sounds really sexy, but maybe isn't that great of like a patient-centered decision making,
Yep.
or what sounds not sexy but is very real of punt it to the primary care provider.
Yeah.
I have these patients who are on anticoagulation. I'm worried for stroke prevention. I mean, 2% a year. I'm thinking, and I say this all the time when like people are worried about me holding the anticoagulation on a patient in AFib in the hospital who's going to have surgery or something. I'm like, if it's 2% a year, their day-to-day risk of having a stroke is so
So
low,
low,
which
so
kind
low.
of gives me a little bit of cover to be like, this isn't an urgent decision. And I'm going to kind of defer it to the primary care provider because I am worried that this same person whose CHADS VASc is elevated for whatever reasons also falls. And I'm worried, you know, I'm always having the question for them, like, which is worse, you bleeding out in your brain or you having an ischemic stroke?
I think the interesting part about this thing that we're getting to is they were specifically talking about people who came in with hip fractures because they fell down.
Yeah.
And this week alone, I have been admitting this week, and we have admitted someone who, a healthy person with AFib, fell down playing golf, broke a hip. A healthy person with AFib and sick sinus syndrome fell down playing tennis. So I've literally encountered this twice in the last week, and these are healthy people, let alone the frail people that are falling all the time.
And you know what's terrifying? Um, Brain bleeds.
Yeah, real
And, you
scary.
know, when they go bad, they go really bad. And so we
Yeah,
see that, and I'm like, I very much I've kicked a lot of cans down the road when it comes to this, whether it's in a patient who's already been on the anticoagulation or I'm diagnosing AFib new. And I'm saying, you know, it's tough. You are at increased risk of bleeding. It's just like a tough conversation to have and to
always.
put on the patient, which is part of like, I am like very much in favor of like involving your patient in the decisions you make,
Of
but
course.
also it's such a hard decision to make.
And
I'm
I
a little bit
just
like my
don't
thought
have.
process is, would you rather like have a stroke and be bedbound or have a brain bleed and maybe die quickly,
Maybe
but
also
also
be
maybe be
bedbound.
bedbound? And I'm usually like, I'd probably rather bleed out. And so
Yeah.
I would pick the anticoagulation.
But it's hard because that's a lot of information for someone who's not medical that
Oh,
you're talking
totally.
to about. And then you say like 2% a year, and people think that's very little,
Right.
but we've all seen it.
As I'm saying in my
Yeah.
like day to day, I'm like 2 divided by 365 is very little. But no, I mean, and it's
Yeah.
terrible. I mean,
Yeah.
strokes are terrible and
All of this stuff is
often quite
terrible.
life altering. Yeah,
Yeah.
totally. All this stuff is terrible. And so I was very this was not on my radar. I hadn't like dug into the literature in this. This is one of those things I just like was like, oh, it's a risk benefit decision.
Yes.
And so I was impressed by this session where they talked a lot about things we do for no reason, holding the anticoagulation in folks who were concerned about for fall risk
Yeah.
if they're on anticoagulation for AFib, because the risk of your stroke and the morbidity that comes with that is so much higher than your risk of falling and having a brain bleed that's going to end or change your life.
Yeah.
And so
This is one of your favorite number needed to treats, right?
yeah, yeah, yeah. I don't even yeah, let's see. I was impressed by the quality adjusted life years that they had more than anything. Trying to think where my notes are on this. Yeah. Oh yeah. The fact that so the study looked at what's the difference in quality adjusted life years and no anticoagulation versus anticoagulation with a bunch of trash that I wouldn't treat anyone with versus just doing Eliquis.
Right.
And the really impressive number to which you are alluding was greater than 458 falls a year is what you have to have so that your quality adjusted life years would be less on anticoagulation than or less off of anticoagulation than
So
on it.
you're telling me if I'm holding the anticoagulation, I have to assume that the patient is going to fall more than 450 times a year
That
for the
is correct.
benefit to be there.
That is correct.
That is shocking.
Right?
Yeah.
Isn't that wild? And
I
it was
wish I
like
published that study. That is amazing.
3.5 years more quality years of life being on anticoagulation versus not in something that I'm like, it's a risk versus benefit. I don't really know. It's a hard conversation that I don't know that I have time for. And so I'm a little bit punty or hedgy about it. And sometimes
Right.
just do it. And sometimes they're just like PCP. And this is 3.5 years of people's lives. And this could get missed some other
Yeah.
time. This is another one of those things. Like so far, all of our studies have been sort of how the hospitalist you get a touch point on people. Like this hasn't really totally been hospital medicine, a
Right.
flu shot and anticoagulation
Of
for
course.
AFib and coronary artery
Yep.
disease. This is like primary care, but we as hospitalists get this touch point
Exactly.
and we can make this change. And so these people might not get another opportunity for me to tell them,
But you put it
be
to
on the
yeah,
Eliquis.
you put it to the PCP has 4 minutes in a conversation
Oh,
of their
totally.
entire hospitalization, and maybe they have a 20-minute appointment, and then, like, they can dedicate 3 to 4 minutes to the anticoagulation. It's if we can do that on the front end and already have had that conversation, then that's gonna save everybody in the system and probably have better outcomes because you can have a thoughtful conversation. Because I mean, we're seeing 14 to 17 and they're still seeing 22 out there in the outpatient
Totally.
world.
Totally.
And so it's just a conversation that is probably better to have inpatient unless that somebody has a very specific PCP that they have a different trust with. But
Sure, sure.
I think it's something we should certainly bring up.
Yep.
The 450 falls a year is
Yeah.
shocking.
I should be getting everyone on AFib. Um,
Yeah.
Everyone with AFib should be getting them on anticoagulation, essentially Eliquis.
Yep.
Um, and so huge will definitely change my practice
I'll
and
be more
will
aggressive, I think.
give people increased quality years.
Yeah. We should mention, though, they did not mention anything about GI bleeding
Yes,
or any
agreed.
other kind of
Yeah,
bleeding.
one of our colleagues was like, "Yeah, hey, what about the people who are just like bleeding a bunch?" And so then that totally
That
changes
changes
your calculus.
yeah.
And maybe they didn't give us any good data on this, but yeah, when we talked to at lunch to Dr. Maggie Thomas about it, she said, "Yeah, what about people who are bleeding their gut?" And you're like, "Yeah, that's a good point." And that is, I think,
That's a
as
caveat.
far as I know, that pushes us back into the mush land of risk
Yeah.
versus benefit. Like we've all had people who, particularly at tertiary referrals, that you've sent someone to for like a push neuroscopy that just like has AVMs that bleed constantly and they
Yes.
live in the hospital. I'm stopping that person's anticoagulation so
Yes.
that they can live at home.
Yeah. As best they can.
Yeah, right.
Yeah. Agreed.
Yeah, so that's a horse of a different color. All right. Uh, you wanna pivot and talk about alcohol stuff?
I do. Mason and I both went to a wonderful session on alcohol use disorder and the
Fantastic
treatment.
speakers.
Yeah, shout out Dr. Carrie Holmes Maybank. She was amazing. A lot of very interesting things are coming out about alcohol use disorder. And it's easy to say everybody knows how to treat alcohol use. Everybody knows how to treat withdrawal. You just put them on the benzo, you just ride it out. Um, and that's all well and good. And it's successful in a lot of these people, but there have been in our hospital specifically, we've had a lot of this, and this is probably in bigger medical centers, but certainly is trickling down to everyone. The ER is just throwing phenobarb at people,
Oh, yeah.
and we don't know what to do with it once they come upstairs on phenobarb, like with a phenobarb load. Um, and so we talked about that, and it was very helpful to hear the perspective and why this is happening, which is the ER can more easily administer phenobarb. It lasts longer. It has a long taper. And their literature is going to start saying that this phenobarb is the gold standard. It's easier for a nurse to administer. They don't have to be at bedside for as
Mhm.
long. This is starting to be the ER's gold standard. So we discussed whether or not it should be our gold standard. And, all of this is still up in the air about the long-term dosing and all of those things, whether we should dose phenobarb with a benzo, whether we should do it by itself. But the big news on this is that this is not going away.
Mhm.
There's starting to be more studies about the actual taper that we should be using and all of those things. And honestly, for me, I felt more comfortable with phenobarb
Mhm.
afterwards. I know that many hospitals are coming up with standard protocols, and that will be very helpful. But it's coming from the ER. These patients are already on it. It is. It sounds like as of now, it is safe to use with a benzo. So if you feel more comfortable
Mhm.
starting benzos on the floor, it is fine that they've been phenobarb loaded. But also, if you want to try it just by itself, it seems like that's successful too. I don't have the exact doses, but you had to give a lot of it for it to
Mhm.
be without like outside the therapeutic window. It's safer and then patients respond better. So still with the CEWA protocol on board and all of those things seems appropriate, but phenobarb was something that was, to me, very scary, and when we walked into that session, I was like, "All I need out of this is they're gonna talk about phenobarb, and I'm just gonna figure out what to do about it because it's been something that's been weighing on me that I feel out of touch,
Yeah,
per se."
yeah. Yeah, phenobarb is the kind of thing that, like, when we learned about really barbiturates in general in med
Yeah,
school, it was like, "This is a historic medication that we do not use anymore." And
no.
now we're using it, the
We're
ED's using
back,
it every
baby.
day, yeah. And so, I was I had a little bit of a I had a little bit of a disappointment, not from the session and not from the speakers, but from where the literature's at.
Yeah,
Actually, in one of our previous episodes, featured a phenobarb article that was like not a randomized controlled trial. It was literally a natural experiment of IV lorazepams out.
yeah,
People are using phenobarb more, and hey, look, outcomes are better. Wait times in the ED are better. Hospital length of stay was better, but like not incredibly rigorous. And my impression from the session was still we don't have incredibly rigorous literature. It feels like we're so close.
it seems like there's a lot of stuff going on, and I think stay tuned to SHM next year
Right.
because I
And
think
like
there'll be stuff next
the
year.
signal, like it makes sense and
It's
the
there.
signal is clear and the studies are clear that this is good stuff and it works. But I wanted like
I wanted someone telling me how to
I
dose
wanted
it.
the end
Yeah,
of Siwa, I wanted
yeah,
the end of benzos, I wanted and we're not quite there yet. I think we are from we
yeah.
could make a protocol, we could be doing it, and it would be just as good, and we don't have any indication it wouldn't be, but I don't think we're there from, like, look at my randomized control trial that tells me the benzos are
Yeah.
dead for inpatient
And
management
it's
of
gonna have to be such a culture
DTs.
change that I think you have to have,
Yeah,
like, a
I know, totally
really
agree. We're gonna
good,
need
rigorous studies, like, randomized controlled trial studies before everyone is ready to switch the culture of mass hospitals. So, like, this is what almost everybody does. And they also talked about SIWA versus some other metrics, and SIWA is not the best. But again, the amount of culture change that you would have to switch to M-Minds or something else would be
mm,
amazingly hard. And it really is going to have to be proven in studies before any institution is ready to do that. So that one's a TBD, but also definitely on the horizon and something that is coming down the
yeah,
pipeline.
and you talk to a pharmacist about it, at least at our institution, and some of them, they are so excited about
They're
the
psyched.
phenobarb. Because
Yeah.
I mean, yeah, for all the reasons that it's so much more convenient, um, and also just, like, intuitively, really quick onset of action, so you can give it again and again and not worry that you're gonna double stack because it's gonna build up in your
Yep.
system after. And also a half-life of, like, 4
4
days.
days.
It's covering you for your entire it is self-tapering, covering you for the entire window. I mean, it really makes sense that, like, you could do this a few times in the ED, and we do not need to be admitting people for
Yeah.
DTs or concerned for complicated withdrawal anymore. Like, that's what it and that's part of why I say I'm a
And
little
maybe we'll get
disappointed
there.
because I feel like that's the horizon,
Yeah.
and we're so close, but we're just
I
not quite there yet.
think there's gonna be a point where we're admitting fewer.
Yeah.
There you're gonna have already demonstrated complicated withdrawal, but there are these people that are refractory to benzos, and this is out there, and this is happening. So this may become something that's better treated in the ER, which I mean, I know from our hospital that would be great. If we could save 5 or 6 days hospitalizations for these things, and you were watching them maybe 24 hours,
Yep.
or maybe
Totally.
in the ER obs, like there are lots of opportunities for advancement, I think.
But I do feel yeah, I feel more confident about it, and if nothing else other than, like, looking at some dosing on up to date, I feel like I could do it, and I don't
And our
totally get
pharmacist
concerned.
will
I know.
and every pharmacist is gonna help you with that. Like,
Oh,
the
totally.
taper is it's easily figure outable. It's not something I feel comfortable with, but there seems to be many different ways you can do it, and it's hard to give too much,
Yeah,
which is nice.
cool. Very exciting. Um,
There's one more thing from that session I wanted to bring up because this is also something that I am gonna change in my practice that I have not done previously, and that's using naltrexone as an inpatient.
mhm.
And I I will say that it has always made me very nervous to use it in patients who are still tapering their withdrawal, but still withdrawing. And the studies have proven that for people, unless even in cirrhosis, unless their
Mhm,
child's Pew-C or greater, so horribly decompensated cirrhosis, it is safe. It is safe essentially probably after 48, 72 hours of being inpatient, even if they're getting some stuff for withdrawal concurrently. But the studies are so good about the decrease in
mhm,
alcohol amount. And it's not necessarily that these people are going home and abstaining from alcohol, because that's kind of a pie in the sky goal, especially if an alcoholic has been admitted several times, has been to rehab several times. This is really hard to say we're going to have complete abstinence. But what it does aggressively do is decrease cravings, and it decreases your alcohol drinks per day, and it increases your alcohol-free days.
mhm,
So overall, getting it started in someone who is very interested in remaining abstinent from alcohol at discharge, getting it started the day of discharge or the day before that, because there are some side effects associated with it on the front end. But getting it started, making sure they tolerate it, and sending them home with it, it seems to be incredibly beneficial for readmissions for alcohol abuse or things like that. So that's something that I'm going to change in my practice that I have not had. It's been on my radar, but it's not something that I was convinced until this that we went to.
yeah, agreed. This felt like this was a perfect just sit the hospitalist down and tell them, "You really should be doing
Yeah.
this." Because it's the kind of thing that, like, as a working hospitalist, you're, like, aware of naltrexone, it's on my radar, but I don't have any comfort with it.
Isn't that an outpatient medicine?
Right, yeah, exactly, exactly.
Yeah.
Um But I was compelled by the literature. It was helpful to talk about the side effects because, like, this is stuff, like, I literally just, like, I'm like, "That's a medicine. I know about it. I know it should be used. I used it one time. I know there's something about liver disease." But she, like, highlighted the things we do for no reason, and that's holding in liver disease article.
Yeah.
Like, it I thought it was very helpful to sit me down and say, "Yes, use this. This is your opportunity," just like some of the other studies we've talked about of getting that touch point with someone with alcohol use disorder more than anybody almost.
Yep.
Take that touch point of they're here, you can do something for them and give them this medicine that will, like she talked about, not only decrease the amount they drink, but actually decrease cravings and decrease or treat the disorder itself.
Yes.
Like some
Yeah.
of that sort of mentality of thinking about it, of like the cravings are the disorder, I thought was interesting and helpful. So yeah, I'm with you. I'm grateful I was sat down and told, like, seriously, just be doing this. And unless they have horrendous liver disease, just be like starting everyone on naltrexone that you're admitting and giving this phenobarb to and
Yeah.
all of this,
All this
as
has to
long as
be
they're
is a
down to quit.
conversation. Like, it just has to be a conversation with these people, and, this is a population that a lot of times I feel like is stigmatized, and we see a patient multiple times, and the hospital is, multiple times in 6 months, and you're thinking, "They're never gonna be able to quit. Like, what are you doing?" And, maybe we have the resources that we can give them that are different than just counseling and things like that. All of that stuff is great, but, like, if there is a medication that eventually is gonna help decrease cravings, that's great.
Yeah, super cool. Um, all right, hands down, or cards on the table. If you have to pick a favorite session from the whole event, what was your favorite session?
I know we've referenced this one, and we've talked about multiple things that we've had from this session, but Things We Do for No
Yeah.
Reason is my favorite session. They are dynamic speakers.
Mhm.
Um, this is the 10-year anniversary. Is that what
Yeah.
they said?
Yep. That's what they said.
And they went from publishing an article in the Hospitalist magazine every quarter to every month, because there's a lot of fat that we can trim,
Mhm.
and it's a very important thing, to be on the lookout for, that there is stuff that we are doing that is too much. We are over ordering. We are for stuff that's not making a difference. And this in general is they highlighted 4 things that I can make a difference tomorrow by dealing with. So, I think that's a big deal.
Yeah, I agree. I thought that was super cool, and Indy, my dog, agrees.
Yeah.
She's shouting her praise.
She's a big fan.
Things we do for no
She
reason.
thinks we do a lot of things for no
Yeah,
reason.
honestly, I do think that was the session. I mean, multiple things we've talked about here, they at least touched on. I thought that was huge. Um,
Any
all
clinical update is big for me, though.
Yeah,
I like all of those.
yeah. Looking back at the slides, a lot of sessions, I was like, when I just heard update in general topic, I'm like, that just sounds so broad. But then I look back at the slides and I'm like, this is great. I'm sad I
Lots
missed
of
it.
stuff changing. Yeah.
Lots of stuff is changing.
Yeah.
I'll shout out the anticoagulation talk. It was something about like updates and what's going on with anticoagulation with a lot of references to hot chicken.
Yeah. Of course.
In it because similarly, multiple things we've talked about have been a takeaway there. It's like
They're
things are
changing.
hot,
They're hot.
hot chicken.
Yeah.
Things are
Hot
hot
takes.
in anticoagulation right now, and it's really simple stuff and really powerful stuff, and a similarly good speaker. And he did a goofy thing where he told us the history of Nashville hot chicken, but more importantly,
Very important.
he also did what I liked. He said, "Here's a study that came out recently. I think they were all within the past year, but at least recently." And he said, me as an expert in this is what I'm doing different in my practice. And that was his summary
That's very
slide.
helpful.
These are the studies. This is what I'm doing different. And some of it was kind of hedgy and some of it was really direct. I thought that was really excellent
I
session.
think anything that summarizes the cardiology, the vast literature is helpful
Mm-hmm.
because they love to study an anticoagulant. And,
Yes.
that's kind of great because that all trickles down to us. And there are cardiology things that cardiology is not involved in when we admit patients. And it's great for us to have more guidance in that. So, I missed that talk, but I mean, the amount of other talks that were clinical updates and other things that had anticoagulation changes in it were, I mean, almost every single one of them.
Yep.
So
Yeah. Yeah.
that
Was
that
really,
one's hot. That one's
that is
yeah.
hot.
I
It's a
guess
hot chicken.
we're gonna have some talks about that one later in future episodes.
Oh yeah. And
Yeah.
yeah. Oh, and also I felt very felt pretty good about myself of like the updates in hospital medicine, like maybe half of the major articles they featured. I was like, you could have already known about that if you just listened to Inpatient Update
Very
wherever
important.
you get
You
podcasts.
guys, this is late breaking news.
Um, uh, any good poster sessions? Because I saw an excellent poster. I think it won a blue ribbon. Do you remember
It
who
was
won first place in the
it was
poster for innovation?
it was a green ribbon. Just so we're all aware, but
It was actually green.
yeah, it was a dark green ribbon.
Oh, I didn't. I heard talk of green. I didn't realize the first place ribbon was green.
Yeah, I'll have to show it to you because our telemedicine program won that. But yeah, it was this is the only reason I went to SHM was to present this poster, and I'm glad I went for many other reasons, but yeah, we put together a telemedicine program several years ago and it is innovative. And we are changing what's possible for all kinds of South Carolinians. So it's especially important for rural South Carolinians. So
Yeah, super cool stuff, and obviously, like, legitimately innovative because it's like our the work on that has won multiple awards.
yep. And
Um,
we're the only ones doing it, but we're hoping to teach and spread elsewhere because the entire nation needs this. I was accosted by an amazing amount of hospitalists who needed to figure out the details of how this worked because their states need it too. So it is innovative. It is something that we are very proud of and something that is interesting for everyone. So more to come.
all the listeners are going, "Oh, this makes sense. This silky smooth voice is clearly someone who is on the phone and talking to people
She's
purely
gotten
verbally for, a
yeah.
significant portion
She
of
runs
her
most of
job
her
coming and
rounds
going."
via phone. Yes, via phone and iPad. Oh my
Got
god.
it. Alright, so we've had several great takeaways, and now we're gonna transition into stuff that perked our clinical ears, but we, also perked our skepticism or maybe just moved us or, um addressed us in our very ensconced place as people who've been practicing a hospitalist for multiples of years. Um,
Decades?
um, speak for yourself.
I will.
But yeah, you wanna lead us on a journey?
Yeah,
You start
I'll
our
start.
journey and then we'll move.
Yeah, so, we went to this amazing session called Clinical Updates in Hospital Medicine. It's their main session where everyone is in a ballroom,
Mhm.
and what there 5 all 5,000 of us are there, and they led us through 6 or 8, maybe even 10 things that were on the horizon, big clinical updates for the hospitalist. Like, these are the things you should take away from this entire session. And I will tell you, we've talked about a couple of them, but the first one they talked about, everyone was really uncomfortable. And it's, do we hold metformin in the hospital?
Yeah.
And did you go through an internal medicine residency? You hold metformin in the hospital. How dare you even question that?
Have you, been on a co-management service and berated someone else who did a med rec
Have you
and
yelled at an ortho intern about this? So I will tell you, the study was very interesting. It was a large VA retrospective uh, large VA retrospective trial about metformin being held in the hospital versus giving metformin during a hospitalization. It seems like the outcomes are showing that at discharge, if you've given metformin during the hospitalization, you're less likely to have an insulin prescription at
Mhm.
discharge. You're also less likely to have a hypoglycemic episode post discharge. And they did show a little bit of decrease in readmission, which is interesting. And I think for me, my takeaway isn't I'm going to give everybody their metformin because that seems too broad. But my takeaway maybe is some people can have their metformin if they're in for very like a cellulitis or something like that, where where their sugars are a little more dysregulated than they normally are.
I've been hearing murmurs of this for a while
Yeah,
where like, yeah, 100%. I stop everyone's metformin when they're get admitted. I've told more people than I can ever count. That's what you do.
that's just what you
Just like as a
do.
resident, like the
Yeah.
interns, they can't, that's what you
Med
do.
students, you have to
And you
teach
throw
them.
them on sliding scale insulin. You hold their home orals and throw them on sliding scale insulin. And that's just how you be a hospitalist. That's
Yeah,
how you be an inpatient
that's
doctor.
just what we do.
And I've been hearing these rumblings and have not paid it much attention. And I think I'm probably have ended up like the butt of a joke and like they're like, "Yeah, now we have this data, but we've been doing this forever, right?" And
But
I'm
why
like,
are we doing it, and what is the benefit? And I do think in someone who's super sick, giving metformin is probably not the right answer. But maybe in these, like, patients who are in for ops, it might be the right answer. But also, I think the real takeaway is we should be mindful what kinda insulin we're discharging people on.
yeah,
And that's always been something that's scary for me. As someone comes in and they're a new diabetic and, what do we send them home on? And
oh
the
yeah,
guidelines are terrible. And for this, I think that this just highlights that we need better studies on what we're doing with diabetics at discharge.
transitions of care for new
Yeah.
diabetes. Yeah, no, that is one another one of those
New
things where I'm like,
diabetics. Yeah. People who,
"Pharmacist, help me, somebody help me," because that
yeah.
is very uncomfortable.
Yeah, and we're sending a lot of people home with new insulin, and they're in an acute sepsis or an acute infection. A cellulitis is a perfect example, a pneumonia, a flu, where their sugars are high. And do we need to send them home on the 20 of Lantus? Probably not.
Mhm.
We need to be more comfortable with sugars being high for a little bit if they're not in DKA. And I think that my take home point is I need to think more about metformin.
Yeah. I was with the crew of people, which was most of our crew sitting there during the session being like, yeah, I don't know. This doesn't feel like you've really thought this through. It feels like bad things can happen. I don't know. I don't know. I don't know. But in my combination of doing exclusively two things and reviewing this, and one, quickly asking open evidence, why do we do this? And should I be doing this?
Open evidence is
And
so smart.
looking back at the slides from the study, and now I'm thinking probably like, oh no, I think maybe I'm on board. I
Interesting.
I haven't been totally clear, like, why do we stop the metformin? It's just the lactic acidosis we're worried about?
Right, the IV contrast with the metformin causing a lactic acidosis that is undialysable.
Yeah,
Um,
because it's a different lactic acid?
Evidently,
Yeah, see,
it's a
I don't totally understand, and so
so
I could be I'm impressionable on this
I'm
topic
impressionable.
because I don't totally get it, and so if they tell me I'll tell you what open evidence said was, yeah, hold it particularly basically in anyone you think is gonna have a lactic acidosis that stay or
Right.
has impaired renal function. So, yeah, no, that totally makes sense that particularly in impaired renal function, but they were like sepsis, etcetera. But this study, when I look back at it, knowing my open evidence quick search I did, they included people who were admitted for sepsis in this study, and
Yeah.
they continued their metformin, and they did better, and they didn't do worse.
Yeah, it's an interesting study because it's retrospective. The initial
Mhm.
study was retrospective, and it's really that means that was all based on the clinician's gestalt,
Mhm.
which is always kinda difficult for me. I think the way this is gonna change things for me,
Mhm.
I may not continue everyone's metformin at the beginning of the hospitalization, but I may start it a day or 2 before they go home. If I think that there's an issue with glucose and things like that, we may have I just feel like we may have the need for more evidence before I feel really comfortable starting it, and I'm an old hospitalist.
Yeah, and I'll tell you, open evidence did tell me, I asked specifically as a follow-up question, like, "Yeah, but, like, contrast in the metformin and lactic acidosis," and they were like, "Current guidelines for radiologists are basically as long as GFR is greater than 30, the metformin's fine." And I think about it, it's like, how often do I get a CT with contrast on someone who took metformin that morning who came into the ED? And that's the answer is everyone who walks into the emergency department, it feels like.
Yeah, but how
And
many of those people have GFRs less than 30? And it's very little because we don't prescribe that medication to the people who have GFRs less than
And
30.
I'm not seeing the problems in these people when I admit them to the hospital. It's very rarely that I'm like, this lactic acidosis is from the metformin and the CT of abdomen with contrast that they got
Right.
when they were in the ED, and they took their metformin that morning.
So I
They
feel
didn't hold
like
it
you're
before.
convincing me that maybe the issue is the GFR less than or greater than 30.
That
And if
was
they're actively looking at that and that's been the cutoff, then maybe we do continue the metformin. But also, I really think the take home is just be careful what you're sending home diabetics on.
yep,
It's
totally.
what is happening at home is so different than what's happening in the hospital. And
Hypoglycemia is bad and scary.
it's bad and scary, and hyperglycemia can be dealt with. A reading of high on someone's glucometer is a lot less scary than a reading of low.
Mhm.
So, I think met and I think more studies need to be done. And I think metformin may have lost some stigma.
Yeah,
So,
I think
good for her.
I'm gonna for her. I'm gonna keep if GFR is greater than 30 and they don't have lactic acidosis, I think I'm gonna try and just like continuing it.
You're
It
gonna do
makes me
that
I
with
just, like,
your
saying that out loud, I'm not confident that I'm gonna do it
Are you
'cause,
gonna do that on your learner teams?
uh
You're gonna tell your
oh,
learners
yeah,
to do
well, no,
that?
I'm gonna cite this article on it
Yeah,
learners.
yeah. Have them
So,
look into it. I think
we
that
may
sounds
do a
good.
full episode on this article and really delve into it because I'm medium convinced, I would say.
I think it's such a wild, move from what we've always been taught
Totally.
that I would love to see it change. If it needs to change, I would love to see that, but it's
Yeah.
gonna be hard, and it's gonna need there are gonna be multiple articles before that.
Hand in hand with this, one thing that they, like, kind of offhandedly mentioned in the things we do for no reason, and they were like, sliding scale insulin monotherapy, and this is another thing I've heard rumblings about, and I'll be honest, I haven't, like, looked into this in
Same.
detail since,
Yeah.
but I'm like, "Excuse me?
We
And
do that exclusively.
yeah, and they even said offhandedly in the session, they were like, "Yeah, I think everyone's doing this one already, not doing this anymore because we do it for no reason." I'm like, "I do that all the time." And what I think, and I'll look into it more and in the
Again,
future.
something that might be good for another episode.
Right, totally, because I think my takeaway after sitting through a separate diabetes session where I thought they would mention it, I could get it from there, and they didn't, but was that basically like, yeah, you shouldn't just be doing sliding scale insulin, but we're not. Is that was kind of my takeaway because I order a sliding scale insulin monotherapy and hold the metformin on all my diabetics that I admit home, whatever the home rules are. But either they're getting that insulin, in which case I'm saving myself a page from just putting in sugar checks, and they're like, "Okay, the sugar's 300. What do you
Right.
want me to do?" You've got your sliding scale that's covered. And then I'm seeing what's been their insulin need on the sliding scale, and then I'm giving some long acting. And
100%.
so I think maybe we're already doing this. That's my like kind of I need to look into it more, but my kind of my
Do you
takeaway
think this is the dig at the surgeons who are just putting in Q4s and just being like, let it
and just like
fly?
letting them
And when
be in the
things are
300s all the
bad,
time and getting
they just are like, let's do
5
high
or
dose.
10 or whatever it
Yeah.
is every at 4 hours or
I
whatever.
hope that's what they're talking.
I
I
think
again,
so. I think so.
yeah, I didn't
That's
go
my
to that,
takeaway.
and I think all of us are using the sliding scale to move us to a long acting if we need to. Like if we're using so much sliding scale, but also I use the sliding scale if my patient hasn't used it in 3 days and they're eating normal food, I take it away,
Right.
and
Because
they're
their sugars have been good. And I think
yeah,
that was kind of the takeaway. Like, if their sugars are high, they should be on long acting. If their sugars aren't high, they should be on it. But when I'm admitting them, I don't know yet.
right,
So I'm putting them on sliding scale, probably low dose sliding scale, and we'll just see what they need. And then I'll decide on hospital day number
agreed.
2 or 3, et cetera,
I
and
think
go
if
from
we
there.
use it as an information, that's really what we're doing here. We have to use it.
Okay.
Okay. As long as we are using it to make sure we're making the best decision for the patient instead of just leaving it and letting it fly no matter what happens.
My
Or
current
if it gets worse, you go up.
Yeah, my current takeaway, unless we do a full episode on this, is I should probably pay more attention than I embarrassingly do on exactly every day. What was my patient's insulin need on sliding scale the previous day and changing that over into something long acting if it's not adequate and not just sort of like
Yeah.
kind of ignoring it.
I think it
Um,
depends on obviously your patient load and how low that is on the totem pole.
Um, okay, those I would say those are our biggest takeaways, but we kind of have talked a little bit in talking about the metformin of is there anything else that you think was overhyped at this conference? Anything else you thought like was not fully baked yet as far as the literature, like, they mentioned it, but I don't think I'm there. I disagree. Anything else other than maybe metformin? We're both like,
Yeah,
maybe we're convinced,
maybe.
maybe we're
Yeah.
not.
I'm
We probably just need to, shake the vending machine back and forth at food times before it comes
probably. We'll see.
down.
Um, I and we've talked about this. I think that for me, the most overhyped was AI.
Oh, yeah.
I There were multiple sessions. The keynote session was about AI, and I think it's great. Like, I think AI is gonna be something that is very helpful for us in the future, but for right now, everything they were presenting was gonna cost me more time. Very little is saving me time until I can go to an AI session, and I'm old. So I've been doing
Mhm.
this for greater than 10 years, and until I can go to an AI session where they're like, "These are the 3 things you can do that are gonna save you an hour of your day,"
Sure.
writing notes, not having to proofread notes, not having to go back and look at that discharge summary that AI generated. Um, I am not there yet. I think we will be there, but we are not there yet. And I think we jumped the gun a lot with the AI sessions on this thing.
I totally agree. And I mean, that's the time we live in. Like, if you don't have, like, AI in the name is an easy way to
But
get
it's
picked.
so sexy.
Oh, it's so sexy. And I'm a tech adopter. I use AI in my practice and that I use our dictation or our scribe tool some. I'm happy to use I mentioned open
Yep.
evidence. I'm happy to use AI in our practice. I have AI fatigue. I even listened to the Freakonomics podcast about AI in medicine, where the
Yeah.
keynote speaker talked on the podcast. And I'm like, oh, let me listen to that. And it's like almost in this moment. It's been really like it's. I hit the point where I'm like, I'm just tired of hearing about it. I feel like I've heard enough. Like I'm like you. Call me back in a year or two when we have what how this is going to really change my practice and help my patients and save me time. But I'm like, maybe I'm being an ostrich, and like a lot of people in the sessions who are afraid of AI.
Oh, there were some the elderly hospitalists were
Honestly,
nervous. I
you say
include
elderly,
myself.
but it
I include
was
myself.
there
Mhm.
was diversity at the conference. There was diversity in that line of people with the comments on the AI session we attended together
Agreed.
who were like, no one's comment was anything other than like, what is this doing to the education of our learners? And how do we protect patient privacy? And
Yeah.
I'm scared.
Yeah.
And
I
I don't
agree.
and I really have to worry about the learners, but I mean, I think, some of it is just, like, we just gotta accept that this new technology is here and make the best of it, but
I think some of the best comments that I've had about AI was when we were sitting waiting in the airport and we were
mhm,
discussing like maybe throwing every single document that's come from an outside hospital on a transfer into a co-pilot type thing, and we have them generate a one-page hospital summary and tell me when the last time they had antibiotics, tell me what medications they're on, so my med students and residents don't have to learn that their job is reading 400 pages of outside
totally.
hospital transfer. Especially in an academic medical center, that's so important. Um, but I also think that there are things that they still need to do. Like residents and med students still need to do the heart of medicine. They still need to be composing their HMPs and learning how to do
Totally.
that so that when the AI goes awry, they can correct.
Right. If
But
no one has
it's
knows how to
hard.
drive, who's going to intervene when the AIs don't know how to drive anymore? But
Yeah.
that's happening and it's probably just gonna happen and maybe is the way medicine's going, but the stakes are so much higher
We just need to talk
and the
to high school
complexity is so much
teachers
bigger.
about how to deal with learners and AI.
And maybe they have it figured out, but my impression is from the speakers at the AI
Yeah.
session that nobody has it figured out.
No, nobody has it figured
And this
out.
is moving faster than we can handle.
Yeah. But I
Uh,
want us agreed, I want us to train doctors who know how to be doctors and don't rely on a system that at any point could make a mistake or break down or, put us in a liability situation.
but I agree with you. If your institution has a HIPAA compliant large language model, like what better could it be used for than summarizing a document? And so
Yeah.
using that, I think makes a lot of sense. Um, but again, I'm just tired of hearing about it and I'm done. And I'd rather talk about anticoagulation or
I would too. I'd
metformin
rather
or
talk about
whatever
medicine.
else. Yeah, I want to talk about medicine again. And I'm just like,
Yeah.
AI is everywhere and I'm tired of hearing about it. And it was on here too much. The other thing I would say ended up feeling a little overhyped for me, and I probably could have predicted this, was, and you could probably tell from the tone of the things we took away, and that's new medications.
It was hard.
Because I went to a specific session about new medicines, I think maybe you did too,
Yeah.
but just in general, honestly, like all the new guidelines of use this not current or use this expensive medicine for this new reason or use this new expensive medicine. I'm not seeing that change my practice over the next year. I'm not seeing that change my practice until someone in my institution tells me, "Hey, we have
We
this
have
and
this
we can be doing it."
regularly.
So I went excited to the new medicines to know for hospitalist session and came away being like, I don't know if we have that or not. And it's not as powerful as this flu shot or stopping aspirin.
No.
And um
And I think all that stuff, I think that's nice as a horizon. And
mhm,
yeah, maybe we'll be there in 5 years. But these big academic institutions are probably going to be early adopters, and we're not there yet on a lot of these medicines. And a lot of them are very niche, and that's great, but, like, I need something my biggest takeaways are always gonna be something that affects the masses. And so, like, the hepatorenal syndrome
Mhm.
niche
Mhm.
medication is great, incredibly expensive, and that's affects such a small population of what we're dealing with, where a heart failure medicine is obviously gonna be a lot more bang for my buck when I'm in these sessions. So, there is great I'm so glad we're developing more. There's a lot of pharmacological stuff coming down the pipeline, but I feel like that just means more times I'm gonna be on the phone fighting for a prior auth, if I'm
Yep.
really gonna be honest about
Totally.
it.
Totally. Totally. Um, and kind of in that vein, just there were a few other things that I feel like were talked about a lot, or I was intrigued by, or I heard, but I don't feel like I was ready to be like, this is one of my big takeaways. And one of those was, I don't even know if I'm saying it right. Finerenone,
Phen
fin,
Finerenone.
finer,
Finerenone.
and one,
Phenomena.
and one of those ones was finerenone.
Sure, I like that.
Um, but that was one I heard about it multiple times, and anything I heard about multiple times in multiple
3
sessions.
different sessions I went to where they talked about this really sexy non-steroidal MRA with greater receptor selectivity. So it is a very good replacement for where you've used spironolactone in the past. And the studies are phenomenal.
Yeah,
But who has this?
I don't know. And I obviously haven't looked into it. I don't know if we have it or not. I don't know if my patients and sources have it. This has not been on my radar almost at all.
So
I've, like, heard of it before, but it's not been on my
this
radar.
one has been on my radar for about a year because I
Mhm,
read a study about CKD, and it is reducing the quickness in which if you have CKD, diabetes with proteinuria, it reduces your um, progression to end stage renal significantly. I don't have
mhm.
any of the numbers on me, but the new sexy study is in HFpEF. It reduces your heart failure events. So it's not completely studied in HFrEF yet, but it is spironolactone without all the side effects.
Mhm.
It still has hyperkalemia, but none of the side effects, gynecomastia, any of those
Sure.
things, because it's non-steroidal, and it's more selective for the kidneys and the heart, and it looks like this great medication that in 10 years we're gonna be using a lot.
Have you given it to anyone yet?
I've given it to 0 people.
Have you tried?
No, I haven't.
I obviously haven't. I didn't even know about it.
I'm not sure it's available at our facility.
Yeah.
And the heart failure lecturer I went to said, "You need to start this prior to discharge and start the prior to discharge." And
Like everything else.
what I love is when I'm told that I need to start a prior auth prior to discharge. There's nothing more gut wrenching for a hospitalist.
Order your Entresto, your GLP-1, your
Yeah,
SGLT2, and your Plirinone. No, sorry, I'm, like, saying the wrong one. Your brand new potassium-sparing diuretic,
yeah.
that I c obviously
Finerenone.
can finerenone. Order those all when you admit your patient for heart failure, and make sure
Yeah.
you've got
This one
your
I
prior
think
auths
is
done.
gonna make waves. It looks like anything that's better than spironolactone is gonna make waves,
Sure,
because the side effects in general, and they'll probably start looking at it in heart failure, HFrEF, as well as in cirrhosis, which is where we use spironolactone,
sure.
our $4 medication. But there are gonna be people that are not gonna be able to afford this for several years. I think this one is an on horizon. But again, the signal is there on this one. When 3 different speakers talk about it, it makes my ears perk up.
Yeah. 2 other quick takeaways that I had were from the anticoagulation sessions, and these
Those were Mason's favorite sessions.
I loved it. I mean, the podcast lately has been a lot of antibiotics, which I've gotten some feedback about, but it's also been some
Yeah,
anticoagulation because I think
it's
maybe
important.
both of the no, only one of these was in a podcast episode. But one was the Cobra trial,
I
and it
love
was
it.
just like RIP apixaban, except for, I mean, no, sorry, RIP, excuse me, the Cobra style trial, and it was RIP Xarelto. You don't have to worry about it anymore. You don't have to worry about rivaroxaban. I wasn't prescribing you anyways, but now I'm definitely not.
The once a
Um,
day was really tempting.
the only time I was prescribing it is if I heard there was an insurance problem with the apixaban.
Of course.
And I don't have like I'd like to say like I foresaw that there were increased bleeding risks with rivaroxaban, but it wasn't. It was just I was comfortable with
I've always felt
apixaban,
more comfortable with Eliquis.
and so that's what I did.
Yeah.
And so this was a study, had half as many bleeding events on apixaban versus rivaroxaban, and the number needed to treat of 28 for how often. And this was specifically, I believe, yeah, specifically for clots. So not specifically for AFib, but it doesn't
What
matter.
do you think your number needed to treat 28? How many weeks on service? 2?
Yeah. Yeah, yeah.
I mean, the amount of patients we have on anticoagulation is staggering.
Oh, yeah, totally. And so this, I mean, it's honestly not really changing my practice except for reaffirming me not giving rivaroxaban to anyone.
I love the idea of a once-day anticoagulant. I do. That's not warfarin because I have a lot of feelings about warfarin as someone who grew up in the 1980s. I was prescribing a lot of warfarin in the beginning of my practice,
Sure.
and so, like, DOACs have been wonderful, but clearly having a distinguishable event. Initially, I was prescribing Pradaxa, and that had a distinguishable event from apixaban or rivaroxaban, and having now these 2 separate and how good they are at decreasing bleeding risks. Like, that is
Mhm.
very important. This is the problem with hospitalists is it's not the prescribing of these medicines, it's the side effects.
Sure.
And so I'm team Eliquis now. I've been team Eliquis, but I'm cheering from the sidelines now.
Yeah. Yeah, yeah. So
Super Bowl,
totally on
etc.
board there. The other thing, which is just like another touch point of related to anticoagulation, is we should be reducing people's dose either 3 months or 6 months out, depending on why they had the clot, if they're on Eliquis for a clot.
This was shocking to me.
Yeah, again, another thing that, like, hadn't been on my radar, the 6-month, reduction for cancer patients,
Yes.
which that was part of, like, this is what's so impressive is even in cancer patients. But, yeah, it hadn't been on my radar at all, and then that we actually featured that article on a previous episode of Inpatient
Oh, so you
Update.
already knew. Sorry, I
Yeah,
didn't know.
well, but I hadn't been doing it,
Uninformed.
and in fact, my point then was, like, I made fun of someone who was giving half dose Eliquis because 'cause I'm like, they're not age over whatever, renal
Yeah.
function whatever, weight
Wait,
whatever,
whatever.
and it's not for AFib, so none of that applies anyways, they're doing it wrong, and it's like, "No, yeah, egg on my face, I'm
Yeah.
doing it wrong."
Now we've learned.
So
I think that one of a lot of these is one of the most practice changing for me.
sure,
I don't dose reduce for these people that have to be on long-term anticoagulation, especially in cancer patients. I wouldn't have thought to do that. I'm not sure oncologists are doing that yet, so I'm
yeah,
interested.
fun. The speaker at the anticoagulation talk, he said specifically, my practice change is if I have a patient who has cancer, has a clot, is on Eliquis, it's been more than 6 months, I'm reducing their dose. And if I tell their oncologist, I'm FYI telling them I'm not asking them. And
Oh,
so, yeah,
big baller.
because I think this is all based on very recent data, that like a
But you
lot
know
of
who
the
loves data? Oncologists.
yeah, specifically about their chemotherapy drugs for sure.
But this'll
They'll
trickle
do it.
down.
They'll do it.
They love
100%.
data. It'll be fine. This'll be the easiest adapters, like, of
Sure.
all
Yeah,
of us.
hopefully this ends up not being something that's even is from the cancer standpoint in our practice, because obviously cancer patients tend to be pretty well plugged in and their oncologist will just
Yes.
be doing this and we're not taking care of someone in the hospital who it's been a year out. They've got had a clot, they've got cancer, and they're still on full dose. Everyone will be dose reduced. But right now that's not the case. And so
It's not the
we're doing
case.
it.
Yeah,
And then the non-cancer patients that we should be reducing
shocking.
after we've treated treated with full dose for the clot, like when we would stop if it was a provoked, we should just be dose reducing.
Yeah. I love that for them, but if I get a DVT, I'm gonna be pretty annoyed.
Yeah. Actually, the my patient that I was taking care of that had multiple myeloma and a clot and was on half dose anticoagulation, I was admitting him for a clot.
Yeah.
So he
But they did say, I mean, that was the biggest thing is that there were similar rates of recurrent VTE in a dose reduced versus the full dose. Like it was very similar.
Mhm. Oh, yeah.
And I mean, if you're going to chain someone to a lifelong anticoagulation, essentially, I and then the bleeding risk obviously decrease if you're decreasing the dose.
Yeah. I think the situation is basically like if you're gonna clot again, you're gonna clot again.
Yes.
You clot the same, you bleed less,
Yeah.
cut the dose in half.
Bleed less sounds great.
Yeah,
Let's do that.
totally.
Yeah.
You wanna give your take on, red blood cell transfusions for folks with an MI?
Yeah, I would love to. This one is shocking to me, and maybe I'm just behind the times because, the times. But the recommendation is in anyone who has an MI, STEMI, NSTEMI, demand ischemia type 2 in STEMI,
A high sensitivity troponin that's red,
red high sensitive troponin that took at least 2 times to come
AKA the
down.
hospitalized patient.
Um we should be transfusing them to a hemoglobin of 10. And this is a new recommendation that was surprising to me for a lot of reasons. One, because I absolutely wasn't doing it. And two, because it decreased the number of deaths in 30 days by 1.23, which is not insignificant.
I love decreasing deaths.
I do too. Mortality is the worst part of our job.
If these, troponin bumps that are sustained, which is almost all they feel like in these MIs, these
Yeah.
NSTEMIs, these demand ischemias are as prevalent as we talked about, like, what's our number needed to treat there? Like, it's probably pretty good
It's probably
because
pretty
we
good.
take care in that the amount of time we get to them because we take care of so many of those patients.
And I am absolutely not doing this in my practice
Oh,
right
I'm not
now.
either.
Especially maybe absolutely a STEMI, but that's not on my primary service. An NSTEMI, perhaps more. I was aggressively getting them to 8.
Yeah, 8's been my number. I've
And
never done
then
10. I haven't done 10 with
just
anybody.
little like subtle demand ischemia from a pneumonia. I mean, obviously, I know their heart's not great if their high sensitivity troponin jumps to 120 because they have a pneumonia. Sure, I know things about them because of that. But like transfusing to 10 is interesting, and I'm not sure my institution is going to buy into that.
Right. But do you know, I looked at
But it's a blood bank study,
right,
correct?
exactly. So I looked back at because I didn't go to the updates and guidelines session that you did. I looked back at the slides and it was the AABB that recommended
Yeah.
this. That was the guideline. I'm like, I don't know what the AAB is, BB is. So I Google it, American Association of Blood Banks. So it's the blood bank that's recommending it. And then I looked at some of the cardiology. I don't know if it was in that same one or I looked at some other slides from some cardiology sessions. And it doesn't sound like they're totally there yet, our cardiology society. Um,
No, but
but it's
it's
like
leaning that
consider
way.
it's like it's like consider doing it in certain populations is I think the headline I got from the slides I
I
looked
mean,
at
I'm
with
not
that.
sure if I'm doing it in an end-stage renal patient
Sure, sure.
because their troponins are bumped a lot. And do we really know if those troponins are chronically bumped or if that's
Totally.
demand, right?
Totally. And
That's
I'm
a confusing
uncomfortable
blab.
and
But
the volume aspect, and I'm uncomfortable doing it in my
yeah,
heart failure patients for the same reason. It's a lot of volume
or an
and
AFib with RVR that's got some volume on them. Like there are things, but I think that we need to look at putting more blood in these people because they need more forward flow essentially.
I think, gosh, I think we walked out of sessions. You and I went to several sessions together, and there were little things that like made us bristle. And it feels like a little bit like a couple days later, looking at it a little bit more, talking about it. We're not like
I'm doing my
100%.
best not to be an old geezer.
We're not like 100%. Okay, I'm doing this now, but we are a little bit like maybe that's not so crazy. Maybe I'll consider this. I'm going to keep my ear to the ground. I'm going to think about my patients more thoughtfully when it comes to this. Whereas
Yeah,
I was not. It
it
wasn't even
wasn't on
on
my
my
radar.
radar.
Yeah. I
Yeah.
think I think putting the best thing about this meeting was putting stuff on my radar that has been ingrained in me forever. And maybe perhaps that's not the way to be a doctor, which obviously that's not the way to be a doctor. Things change constantly all the time. But a little nugget that I also got from that session,
Mhm.
platelets only need to be 20,000 for LPs. And I've been transfusing up to 50 my
Me too.
entire life. They also included for that minimal IR procedures. The conversations I'm gonna have to have with IR after this.
Yeah. Are they doing this? Are they
But
not
these are
doing
the
this?
new
But I haven't, yeah.
recommendations is that your platelets only need to be 20,000 for LPs, which is great for our malheme population
Oh,
because we are an institution that has a large malheme population, and any academic institution where you're dealing with people that need IT chemo and things like that.
mhm.
This is incredibly important because getting them to 50 is probably detrimental. And this is
Yeah.
still
Oh,
something that has to
totally.
be sussed out, but
50 for the hour that they're getting the LP, and then they disappear
20
because platelets is
minutes.
yeah,
Yeah.
exactly. Exactly.
Um, because those platelets are just being eaten alive. But I think that that is something that will also in the next couple of years trickle down. I'm assuming
Mhm.
that one is going to be more powerful than maybe even the 10 with MIs.
Sure.
But will it's the transfusion stuff again, this has been a very blood heavy talk.
Yeah.
But there was a lot of stuff to still be understood. And I think that us getting some clinical guidance from these sources and having, just a greater understanding of where guidelines are going was important.
Yeah. Agreed. So, we talked about Vegas a little bit. What do you think? Would you go back? Are you gonna I mean, I know you've been before, but are you gonna go again to SHM?
Yeah,
Was it
I
worth
think
your time?
so. I actually kind of it revitalized my interest. I'm a mid-career hospitalist, which is a really aggressive way of saying I'm old. But I think a lot of us get set in our ways, and it's nice to kind of have things shaken up a little bit.
Mhm.
Um, and there was this weird COVID time when everybody was kind of like, I don't know what to do, and like I don't want to go to a meeting. And it's nice to be around a lot of nerds who do what you do.
Yeah.
And I love that I love talking about medicine. I would much rather talk about medicine than AI. But there's a lot of innovations in medicine. There's a lot of things that we can do. And I feel like hospitalists are the people that are saving medicine, that we're on the front lines, just like the PCPs are.
Yeah.
And I think for us, like, it's important to meet with our people and
Mhm.
have these discussions. And also, like, there's a lot of career growth in these things. Like, if that's your jam and you want to climb like the ladder for to do like a lot of inner facility like studies and things like that.
Sure.
This is a great thing for networking.
Definitely.
This is a great thing for clinical updates. It's great for academic hospitalists. It's great for I don't do academics. This is great for just like primary direct patient care. Like I
Mhm.
learned enough stuff that I'm going to change in my practice that I think is going to affect everything I do at least weekly. And that's enough for me.
Oh, totally. I'm with you. If next year there's as much stuff that will change my practice weekly as there was this year,
Yeah.
then I'll feel like I have to go every single year because this was a lot of stuff.
Yeah.
And you're right, being especially post-COVID, when it felt like we would never be in person again, and it felt like didactics would be YouTube videos and virtual for the
Oh,
rest of our
yeah.
lives,
We were just going to be
being
reading
in
open
person
evidence.
with human
Amazing.
beings and
Yeah.
talking to them or hearing them talk in person. And we know like the difference between we went to one session that was unfortunately pre-recorded and these sessions where people were there in person,
Very different.
just being in the room with a human being, I found huge. And so we could bring the take home points to people in podcast form, but there really was something about being in the room with other people that I found really powerful and a ton of new updates. And so I'll definitely try to go again next year.
Yeah. I mean, when you're in a full auditorium with, let's say, 500 people and someone says something up on stage and everybody, like, you literally hear
The
gasps.
feelings. Yeah, yeah,
Yeah.
yeah. Just the
Around you.
energy.
Yeah. And like, nerdy as it is, like, it's like, "Okay, good, I'm not alone in the fact that I didn't know that thing. Like, let's all do this together, let's make changes, let's move medicine along," and in a culture where it feels like medicine is being suppressed a little bit, like,
Totally.
it's nice to have a group of people around you that are trying to push forward, and I
Yeah.
think that's the biggest deal.
To science.
Yo, hey, science. We love you.
Um, okay. In that vein, last thing. If there's one thing that you say, I will do different in the future that you think is going to be most value to your patients going forward, pick one thing. Your one biggest takeaway.
Mine's the stopping aspirin in CAD patients after 6 months after a stent, if they are also concurrently on a DOAC. I think that that is gonna change lives, and I think I can do that every week that I'm on service.
Yep. I think I will counsel people to be on there specifically Eliquis for their
Yes.
AFib and not stop it for their falls. Um, is probably the biggest thing, and that's kind of like
Should
taking
we
2
make
studies
Pro
in one.
Eliquis shirts?
Yes, we should. And in fact, looking for sponsors if Eliquis is interested. I'm here for it. Um, alright, well, cheers.
Mm.
We got a bottle of wine to finish. Anything else you need to say? Anything else you wanna take away? Anything else you wanna add?
No, we would love to see all of you guys at SHM next year. Anybody who's interested with any input and would love to have discussions about all of these sessions in which we learn things that we probably should have read in journals.
I was sitting there, this is, like, dorky of me, but I was sitting there imagining, like, what would Inpatient Update live at SHM look
I
like as
love
a
that.
session?
Let's do
So
it.
I might
Yeah.
submit it. We'll see. Maybe I'll try and be there next year regardless.
Yeah.
So
I think it's good for all of us.
agreed. Well, Dr. Reams, thank you so much for being a travel companion for
Of
me.
course.
We fell
Happy
into
to.
that and it was fantastic.
Happy to go to any honky tonk with you anytime, Dr. Turner.
And thank you so much for joining me today on the podcast.
Absolutely.
All right. And as always, if you're a provider, pharmacist, nurse, resident, or anyone with some value added insight into the management of hospitalized patients, please reach out to me directly or contact me on social media or email me at podcast@inpatientupdate.com. If you would like to be on the show or have ideas for something to talk about on the show, I'd love to have you. And of course, if you are impressed by these like number needed to treats of 17, 15, share this with 17 or 15 people and you will have saved a life or a hospitalization. If you're finding this useful, seriously share it with other clinicians. If you're not finding it useful, that's okay too. And I will shout out a full quarter of my listens to the last episode were from Ecuador. And
Hello.
so shout out to my, loyal listeners in Ecuador. I'd love to hear from you and hear why, Inpatient Update is bopping around Ecuador, and if anyone wants to be on the show, I'd love to have you as well. So as always, thank you, Dr. Reams, so much for joining us,
Glad to be here.
and thank you to the listeners so much for joining us. This has been Inpatient Update.